Okay, let's unpack this. We are diving deep today into one of the most high-stakes, real-world deployments of artificial intelligence happening right now. We're talking about the integration of AI systems into European radiology departments.
And this is a really critical deep dive. It's driven by something much, much heavier than just technological buzz. I mean, unlike a lot of conversations we have about efficiency gains, this one is rooted in absolute urgent necessity.
Right. So what are we looking at today? What's the source material?
We're analyzing a specific stack of research, some proposals, and foundational literature from 2024 and 2025. And they all try to answer this one core question. Is AI an opportunity for transformation, for relief from an unbearable workload? Or is it a fundamental threat to the professional identity and security of radiologists across the continent?
And our sources are specifically focused on European health systems. So it means we're analyzing the practical realities of staffing, of professional perception, and this enormous legally binding structure of the EU AI Act, which, just looms over this entire process.
Exactly. We're moving beyond the algorithm itself.
Yeah, to the operational complexity of deploying it safely and successfully.
And that's really the mission for you, the learner, today. We need to look past the promise of, faster image analysis and really get into the practical realities, the demographics driving the change, the deep-seated psychology of acceptance or rejection among the medical staff.
The professional identity shift?
The identity shift, absolutely. And the heavy governance that's required to make this technology work safely in such a critical medical setting. It's a socio-technical challenge of the highest order. How do you integrate high-risk technology into a human system that's already strained to its limits?
All right, so let's start with that context then. Why is this so urgent? Why now?
To understand the AI conversation in European radiology, you absolutely must start with the workforce crisis. Without this foundational context, everything else, the algorithms, the regulations, the training protocols, it's all secondary. It's almost academic.
So this isn't a case of, wouldn't it be nice to have AI?
Not at all. AI integration is happening not because healthcare systems are flush with cash and looking for shiny new upgrades. It's happening because it's a necessary, immediate response to severe and worsening workforce shortages right across Europe. This shortage is the foundation that all this discussion has to rest on.
We hear about general medical staff shortages a lot, but when you zoom specifically into radiology, the numbers are, well, they're not just worrying, they're wildly uneven. This isn't just scarcity, it's a massive disparity in capacity across the EU. And that must determine where the pressure points truly lie.
Let's pull out some of the stats that really capture this uneven crisis. This is from the Brenny and Ullo data. We're looking at the number of practicing clinical radiologists per million citizens. And the variation across the EU member states is it's dramatic.
How dramatic?
You have countries at the low end with only 51 radiologists per million, and then you have others at the high end reaching 270 per million.
Wait, 51 versus 270? That is more than a five-fold difference in the availability of diagnostic expertise?
Precisely. And that single statistic tells you two things immediately. First, the stress level on the radiologist population in those low-ratio countries must be just astronomical. You're looking at potential burnout, huge diagnostic backlogs.
And the second thing?
The second is that the AI adoption strategy cannot possibly be uniform. It can't be one size fits all. A country with 270 radiologists per million might be looking at AI for optimization, doing things cheaper or a bit faster. But a country at 51, they're purely desperate for survival. They're looking to AI just to handle the volume they otherwise couldn't possibly touch.
It also brings up these fascinating questions about cross-border medicine and just the equity of care. I mean, if I live in a region with 51 radiologists per million, am I getting the same quality, the same timeliness of diagnosis as someone in a region with 5 times that capacity? It feels like it creates inherent structural inequalities in healthcare delivery right across the union.
That's a key insight. And the crisis is systemic. If we look at the average number of radiologists, which is around 127 per million, the data shows that 16 out of the 27 EU member states fall below that average.
16 out of 27. So a majority.
A clear majority. This is not a localized, isolated issue affecting a handful of outliers. It's a systemic capacity problem that affects most of the union and really cements the reality of a diagnostic bottleneck.
But the current capacity issue is only half the story, right? The other half is this demographic cliff edge, the impending retirement wave, that makes this whole AI discussion so time-sensitive. The crisis isn't stabilizing, it's accelerating.
Absolutely. The research points to what you could call a demographic time bomb that should concern every single federal health minister in Europe. Right now, 45% of radiologists in Europe are over 51 years old.
45%, that's nearly half.
Nearly half the workforce is approaching typical retirement age within the next 10 to 15 years.
That's just staggering. And these aren't just, bodies leaving their posts. These are the most experienced professionals. They hold decades of institutional knowledge, nuanced diagnostic skills, mentorship capacity. Losing them signals a massive, unavoidable depletion of that collective human capital.
And the pipeline of new trainees simply isn't sufficient to replace this huge loss. To ground this demographic fear in a really concrete national context, let's look at the situation in the UK. Even though it's not an EU member, it shares very similar demographic trends, and it's a stark illustration of the severity.
Okay, so tell us about the UK data, because that really emphasizes the critical nature of this shortfall.
The data from the Royal College of Radiologists confirms how bad it is. In 2024, so right now, the UK faces a 29% shortfall of clinical radiologists.
And a third.
But if current training and retention trends continue, that shortfall is projected to reach an alarming 39% by 2029.
39%.
Yes. We are talking about 5 years from now, where 4 out of every 10 necessary posts could be vacant.
If that one statistic doesn't make department heads prioritize technological solutions, I honestly don't know what would. A 39% vacancy rate means a fundamental breakdown in the system. The remaining staff would be trying to read, 140% of their intended workload?
Exactly. The potential for human error alone makes that scenario completely unsustainable. And this is the crucial takeaway for you, the listener. We are not discussing AI as some cool optional upgrade, like putting a new stereo in your car. This massive impending shortage, the 45% over 51, the projected 39% shortfall, that is the harsh reality driving the immediate urgent need for AI.
It really forces a narrative shift. The traditional question, will AI replace radiologists, becomes almost less relevant then. Can AI help the remaining radiologists sustain the necessary volume of diagnostic work while maintaining safety and quality?
That's it. It frames AI not as a replacement, but as an essential augmentation tool, a tool that's necessary for the very survival of the diagnostic workflow under this severe demographic duress.
And that necessity must profoundly impact how the technology is received.
It has to. When AI is viewed as a life raft for an overwhelmed professional, their initial resistance might be much lower than if they see it as a tool designed purely to cut costs and staff.
Okay, so we've established this dire need that technology has to address. Now let's pivot to the people on the ground, the professionals who actually have to integrate these complex systems into their daily high-stakes work.
Before we get into the psychology, let's just anchor this discussion in the quantitative reality. Where are European radiologists right now with adoption?
The Zanardo et al. Survey data from 2024 gives us that crucial baseline. And it shows that the adoption landscape is still, it's somewhat fragmented. We see that 48% of European radiologists currently utilize AI in some capacity.
So nearly half the field. That's a significant number.
It is. But the rest of the field is split. 27% explicitly do not utilize AI. And a further 25% have the intention of utilizing AI soon, so they're in the procurement or planning stage. So we have a field that's roughly segmented into current users, firm non-users, and these soon-to-be users. That diversity in adoption must create a rich environment for these different professional perceptions, the whole opportunity versus threat paradox you mentioned at the start. How does this critical workforce view their own job security?
This is where the data might surprise a lot of people. Despite the constant media noise about AI taking jobs, the fear of immediate job loss is actually relatively low. When the European Society of Radiology, the ESR, that's the major professional body guiding the field, when they surveyed their members, about half of the respondents said they do not foresee an impact of AI on job opportunities.
So they're not seeing it as a replacement.
For the most part, no. They largely view AI as a tool that enhances their capabilities, not one that renders them obsolete.
So they believe in a shifting role. Maybe less time on routine tasks and more time on complex interpretation or consultation rather than an obsolete role. That seems like a pretty constructive starting point for integration.
It is constructive, but that perceived opportunity very quickly runs into a massive obstacle. And that obstacle is the social contract between the professional and the patient. This is where the human element creates a really serious friction point for implementation.
You're referring to that stunning patient trust statistic.
Absolutely. This is perhaps one of the most critical insights from the research. A substantial 48% of respondents, so again, almost half the field, believe that AI-only reports would not be accepted by patients. This links the technological challenge directly to the foundational requirement of medical practice, which is trust.
I find this point so important because it suggests the implementation barrier isn't purely about technical accuracy.
Right.
I mean, an algorithm could be statistically better than the average human, but if the patient rejects the diagnosis because it came solely from a machine, the system fails. What's driving this belief among the professionals? Is it liability, ethical duty, professional pride?
It's likely a combination of all three, but the biggest drivers are probably perceived liability and ethical duty. First, liability. The human radiologist is the accountable individual. Even if the AI provides the initial read, the human signs off, taking that ultimate legal and ethical responsibility.
Right, the buck stops with them.
Exactly. And second, professional pride. Diagnosis is a deeply complex pattern recognition task. It often involves contextual patient information that an algorithm might miss. The human signature on that report is a promise that this context has been applied.
And that third factor, the patient's perspective, is the most crucial for the workflow. If a clinician knows their patient will inevitably challenge or doubt an AI-generated diagnosis, they're going to be naturally hesitant to rely on it completely. And that hesitation mandates human verification, which immediately undermines the whole argument for full efficiency gained through automation. The social capital, that trust, is completely non-negotiable.
It solidifies the need for human oversight, not just as a regulatory suggestion, but as a function of market and social necessity. The human element acts as the necessary guarantor of quality and trust in the system.
So let's delve into the deeper, more subjective impacts then. Professional identity and this anxiety around de-skilling. The research, it draws on something called role boundary theory, and it aims to explore how AI changes the actual design of the job. If AI takes over, say, 80% of routine chest X-ray reads, what is the new role boundary for the radiologist?
Well, role boundary theory helps us define the scope and duties of a profession. The anxiety comes from the perceived threat to core expertise. If AI handles routine tasks like flagging microcalcifications or spotting pulmonary nodules, the radiologist's primary value shifts dramatically.
Right.
Does it shift towards complex, rare, multimodal diagnoses, towards patient consultation and multidisciplinary team meetings?
Yeah.
If the fundamental skill, that core skill of image interpretation, is seen as diminishing because of over-reliance on the machine, that causes significant change anxiety.
This is where I see a potential conflict in the data, though. Half of the professionals say they don't fear job loss, yet there's this profound anxiety about de-skilling. Aren't those two things contradictory? If your skills atrophy, doesn't your job security eventually erode?
That is a brilliant point of friction. It suggests professionals believe AI will create new roles for them, roles that rely on sophisticated judgment and systems management. But they worry about the loss of the old skills that validated their professional identity for decades. The fear is not unemployment. It's the fear of becoming a mere button pusher, passively accepting the machine's output without the deep knowledge to challenge it.
But interestingly, we saw a contrast when looking at radiographers, the people who operate the imaging equipment and often perform initial quality checks. They seem to show a different, maybe more optimistic viewpoint.
Yes, the findings from Stogianos et al. Are crucial here. Radiographers, despite being even closer to the front line of automated tasks, showed overall optimistic views about AI use in healthcare. Their role is often focused on image acquisition, quality control, patient positioning, areas where AI can immediately and demonstrably reduce dose, minimize artifacts, and optimize workflow efficiency.
So it's helping them do their core job better.
Exactly. AI is assisting them in producing a better foundational product.
And that optimism wasn't universal, was it? It hinged on a very specific factor.
Correct. The key, and I think groundbreaking insight, was that this optimism was overwhelmingly concentrated among those professionals who had prior AI education and hands-on experience. This is the organizational gold standard. Training and familiarity are the most effective mitigators of professional anxiety and the most successful builders of readiness.
This synthesized conclusion is so critical for administrators. The concept of change and the anxiety that comes with it isn't a fixed trait of the staff. It's malleable. It's directly moderated by how much control or training or positive experience the staff has with the technology. If you feel agency over the tool, you understand its strengths and weaknesses, you perceive opportunity. If it's just imposed on you, you perceive a threat.
And for a system facing critical staff shortages, minimizing this resistance is essential for retention. Maximizing professional agency through focused education becomes a non-negotiable strategy. It transforms the AI implementation problem into a robust curriculum design challenge.
Okay, so let's shift from the psychology of adoption to the institutional environment.
Hmm.
You mentioned some theoretical frameworks that govern how these technologies spread, even before we get to the legal side.
Right. Understanding these models helps us move beyond simple anecdote to systemic analysis. It helps explain why some hospitals are innovators and why others are laggards.
Okay, so what are they?
The foundational research draws on a couple of established sociological and technological adoption frameworks. One is Rogers' diffusion of innovations theory. This theory looks at how, why, and at what rate new ideas and technologies spread through cultures. It focuses on attributes like relative advantage, is the AI better than the old way? Compatibility, does it fit our existing values and systems? Complexity, how hard is it to use?
And a couple others, right?
Yes. Trialability, can I test it without a full commitment? And observability, are the results visible to others?
So if an AI is seen as having high relative advantage, it saves the radiologist 3 hours a day. But high complexity, because it doesn't talk to their picture archiving and communication system, their PCS, which manages all their images. Then the innovation trajectory will just stall.
Precisely. And the second major framework is the Technology Acceptance Model, or TAM. TAM is a bit simpler. It focuses on two key predictors of adoption. Perceived usefulness, will this help me do my job better? And perceived ease of use, is it simple and intuitive to integrate?
So if a radiologist sees the AI as both highly useful, it catches tumors faster, and easy to integrate because it works seamlessly with their IT, adoption is high. But if it's cumbersome, requires constant IT intervention, or is only marginally helpful, it just hits a wall of organizational inertia.
Exactly. And what recent digital health studies have shown is that these innovation trajectories are always anchored on these complex socio-technical factors. The algorithm's accuracy is necessary, but it's not sufficient for success.
The social context, the hospital culture.
The culture, the existing governance structure, these elements can override even the most technically superior AI. And this brings us to the centerpiece of the regulatory discussion, which is unique to Europe, the EU AI Act, specifically Regulation EU 2024-1689.
The EU AI Act is arguably the biggest legislative framework governing AI globally. And its implications for medical imaging are just. They're transformative. It's setting the global standard for governance.
It sets the regulatory guardrails for the entire continent. And the European Union has made a very clear decision regarding medical technology. AI used in medical imaging, specifically in diagnosis and treatment recommendations, is classified as a high-risk system under the Act.
That high-risk classification is the key. That's everything. It means these AI systems aren't treated like a simple word processor or a scheduling software. They are safety critical. A failure could lead directly to patient death or severe harm.
And that classification immediately triggers a rigorous set of mandated requirements for developers, for manufacturers, and for the adopting healthcare institutions. It fundamentally shifts the burden onto everyone involved to prove and maintain compliance continuously. Let's break down the three major pillars of compliance required for these high-risk systems. First, the Act mandates strict quality management systems, or QMS. For an AI system, a QMS isn't just about having a paper trail. It's about documented, standardized procedures covering the entire AI lifecycle. This includes detailed logging of data curation processes, making sure the training data is diverse and unbiased to robust model validation, detailed risk assessment, and change management procedures for when the model is updated.
So if an AI is trained primarily on data from, say, Central Europe, and a hospital in Scandinavia adopts it, the QMS has to document how they validated its performance on the specific patient population and imaging hardware of that Nordic region. It's an ongoing audited process, not just a single performance test.
Exactly. The QMS has to show that the system has been tested against relevant clinical endpoints, not just technical metrics. It's about demonstrating safety and clinical utility within the specific context of use.
The second pillar.
The second, and perhaps the most powerful mandate, is mandatory human oversight. This directly addresses the concerns we heard earlier about professional agency and patient trust. The system absolutely cannot operate autonomously. A human must be responsible for the final output and decision-making.
This regulatory requirement is the ultimate counterargument to the fear of full de-skilling. It legally guarantees the radiologist remains central and accountable. The AI is an assistant, never the final authority.
This legally solidifies the regulatory shield against that AI-only report scenario we talked about. The human is the final accountable link. The Act states that the oversight mechanism must be appropriate to the risk meaning. The radiologist must be able to properly interpret the AI's output, intervene if necessary, and ultimately override the system based on their professional judgment.
Which reinforces the need for that AI education we discussed earlier. You can't oversee what you don't understand.
You can't. And finally, the third pillar is rigorous post-market monitoring. This is crucial because AI models can and do degrade over time. Patient populations change, imaging hardware gets updated, diseases might manifest differently. If the AI model's accuracy drifts, a phenomenon known as model drift, that degradation has to be detected and corrected rapidly.
So it's not a set-it-and-forget-it technology.
Absolutely not. Post-market monitoring means that the hospital, or the manufacturer working with the hospital, must track the performance of the AI continuously in the real-world clinical setting. This shifts AI governance from a single approval process to an ongoing surveillance requirement, ensuring systems stay safe and reliable throughout their entire clinical lifespan.
The implication here is just enormous. This classification shifts the department's focus from simply integrating new technology to ensuring robust governance, transparency, and ethical compliance. And the European Society of Radiology recognizes this profound shift, right?
They do. Through publications, the ESR provides specific recommendations, guiding institutions on how to translate these broad regulatory principles into concrete, manageable clinical protocols for real-world implementation. The European context demands that technological acceleration be matched by regulatory gravity. The high-risk designation means that integration is a major organizational undertaking, not just an IT installation.
Okay, so we've navigated the overwhelming need of the staffing crisis, the human reactions, the mixed feelings moderated by training, and the rigorous regulatory constraints of this high-risk classification. Let's look at the ultimate goal of the research we started with, designing a sustainable, long-term solution.
The core research goal is truly ambitious. It's to design a conceptual framework that explicitly links AI integration and professional agency to inform sustainable organizational models for human-staff AI collaboration. The goal is to create a blueprint for managing this massive institutional change.
And they aren't treating a radiology department like a simple collection of tools and people. They're analyzing it as a highly complex ecosystem, using systems theory.
That's correct. The organizational context is vital. They're conceptualizing radiology departments as complex hubs of diagnosis, data flow, and decision-making. And in a system, everything is interconnected. If you introduce a powerful new tool like AI, it creates ripple effects throughout the workflow, staff training needs, budget allocation, interdepartmental trust. You can't optimize one part without considering the whole.
To manage this complexity, the research proposes using a specific analytical model, the 5 capitals model. This moves the conversation firmly out of the technical realm and into the holistic organizational realm.
This model is designed to categorize and assess the interdependence of different types of capital that are required for successful and sustainable integration. If a hospital is wealthy in one capital but deficient in another, the system is fundamentally unbalanced and the integration will fail. Let's detail these 5 interdependent capitals. The first is human capital. This is the core skill base, the knowledge, the retention rates, the available training, and the professional body support. As we discussed, that demographic cliff edge, 45% over 51, represents a massive impending depletion of human capital.
And successful AI integration requires replenishing that capital through new skills. So investing in human capital means developing sophisticated AI education, not just basic training. It ensures the remaining staff feel competent and retain that professional agency, which mitigates the change anxiety we saw earlier. Low human capital just means burnout and a lack of skilled people to validate the AI's results.
Precisely. The second is technological capital. This focuses on the quality of the AI systems themselves, their accuracy, their robustness, but critically, also the imaging hardware and the integration systems, like the PACS. Low technological capital means systems don't integrate seamlessly, the data quality is poor, or the hardware isn't sufficient to feed the AI reliable inputs.
This links right back to the TAM framework.
Right.
Perceived ease of use. If the technological capital is weak and the AI is constantly crashing or requires complex workarounds to feed it data, its perceived ease of use plummets. And radiologists just revert to manual workflows, rendering the whole investment useless.
Absolutely. The third capital is perhaps the most intangible and maybe the most vital in a service-driven, patient-facing field: social capital. This encompasses teamwork, robust interstaff communication, organizational trust, and crucially, patient trust.
Social capital is where that 48% patient trust statistic lives.
Exactly. If there is low trust between the frontline physicians and the IT department, maybe because of previous failed software rollouts, or if the public distrusts the system because of perceived machine error, the entire system just grinds to a halt. Low social capital looks like physicians not sharing crucial data with the IT team, high internal conflict, or patients demanding a second human-only opinion, which negates the efficiency gain entirely.
Yeah. This capital underpins the functionality of all the others. You can have the best human and technological capital in the world, but without social capital, the output is useless because the patient won't accept it and the staff won't collaborate effectively.
Moving on, we analyze the internal structure of the institution itself. That's organizational capital. This involves the internal culture, the formal workflow processes, and unfortunately, structural obstacles like organizational inertia. Does the hospital culture reward innovation and sensible risk-taking, or is it risk-averse and fragmented?
Organizational inertia is such a powerful barrier. If existing sclerotic workflows can't be redesigned, for example, if the reporting template is rigidly fixed and can't accommodate AI-generated annotations, the AI will only automate inefficiency, or worse, it'll just be sidelined entirely. Organizational capital is the ability of the institution to be flexible, adaptable, and willing to redefine job roles and processes.
And finally, the critical European component, regulatory capital. This is the capacity of the organization to manage and maintain compliance frameworks, specifically under that high-risk designation of the EU AI Act.
This capital determines the institution's ability to demonstrate the required quality management systems, maintain auditable human oversight logs, and conduct that rigorous post-market monitoring.
Low regulatory capital is a huge legal risk. It looks like non-standardized documentation, poorly defined human intervention points, and a lack of continuous surveillance of the model's performance. In Europe, the penalty for having low regulatory capital isn't just poor performance, it's severe legal non-compliance that can halt the entire system's operation.
So this is the key synthesis for you, the listener. If a department has strong human and technological capital, but terrible social capital staff don't trust the AI and weak regulatory capital, the integration will ultimately fail or risk severe legal action. It has to be managed holistically as an interconnected system.
And even with this robust conceptual framework, real-world integration faces predictable, entrenched challenges. Recent digital health studies, particularly those focusing on socio-technical factors, confirm these barriers. We're talking about cultural skepticism that views AI as inherently dangerous, the deep-seated organizational inertia that resists workflow changes.
Fragmented governance.
Fragmented governance opinions across different units, like between radiology, IT, and hospital administration, and economic misalignment, where the short-term cost of implementation far outweighs any immediate demonstrable cost savings.
So what does this entire systems analysis mean for, say, the chief medical officer or the policymaker who's overseeing AI procurement?
It means success is not determined by the algorithm's accuracy alone. It is determined by whether the department can simultaneously manage its human, social, organizational, and regulatory resources effectively. The algorithm is a single component. The successful system is the solution. Ignoring any of these 5 capitals means guaranteeing failure, risking increased staff turnover, diagnostic errors, or crippling regulatory non-compliance under the new high-risk rules. It transforms the simple act of purchasing software into a comprehensive systems architecture challenge that requires C-suite level strategic input.
They're not just buying a tool, they are redesigning their entire operating model, with staff as much a component as the software itself.
Exactly.
This deep dive has shown that AI in European radiology is arguably the most acute, real-world example of technology meeting urgent demographic necessity. Let's quickly review the most crucial insights you can take away from our analysis.
Well, the fundamental, unavoidable insight is the severity of the workforce crisis. 45% of European radiologists are over 51 years old. That signals a demographic cliff edge that mandates technological augmentation merely for the system to survive. This is need-based adoption, not luxury-based optimization.
We also saw the complexity of professional perception. While half of radiologists don't fear losing their jobs, they are highly concerned about de-skilling. And critically, nearly half believe patients will not accept an AI-only report, which shifts the implementation focus immediately from technical efficiency to human accountability and trust.
And that accountability is now enshrined in law. The EU AI Act's designation of medical imaging AI as high risk means that strict quality management systems, mandatory human oversight, and continuous post-market monitoring are not guidelines. They are regulatory minimums across the entire continent.
Finally, we understand that true sustainable success requires a multi-capital system approach. You can't solve a staffing crisis, a human capital problem, with just a superior algorithm, your technological capital. You must simultaneously build the necessary social capital, which is trust, and regulatory capital, which is compliance, to make the whole system resilient.
And for you, the learner, the knowledge gained here, understanding the interplay between professional agency, high-risk regulation, and these severe staffing gaps, it allows you to look at any new technology adoption in any service-driven sector, whether it's healthcare, finance, or logistics, with a truly sophisticated systems-thinking perspective. You now know to look beyond the technology to the deep organizational soil it has to grow in.
And we'll leave you with one final thought that builds directly on the material you've explored.
The conceptual framework we discussed is explicitly focused on designing organizational models for sustainable human-staff AI collaboration. The data clearly tells us that nearly half of radiologists believe patients won't accept AI-only reports. So, given that patient trust is, in itself, a crucial form of social capital that's necessary for the entire diagnostic system to function, how paramount is the preservation of professional agency and mandatory human oversight? Does the regulatory shield of the AI Act, which enforces human oversight, function primarily as a clinical safeguard against diagnostic error? Or does its most critical role actually lie in maintaining the public's confidence and social acceptance of the diagnosis itself?
A system that loses trust, even if it's technically accurate, cannot last. That is a real challenge for policymakers and department heads moving forward. Thank you for joining us for this deep dive into the future of diagnostic imaging. We encourage you to continue exploring these topics.